The topic of the disorders of ani- and dysphagia and GERD, ecclesia cardia, stricture, and CA of the esophagus. Now, esophagus is a muscular tube approximately 20 centimeter in length, which connects the pharynx to the stomach just below the diaphragm. Its only function is to transport food from the mouth to the stomach. In the upper portion of the esophagus, both the outer longitudinal layer and inner muscle layers are striated, whereas in the lower two-thirds of the esophagus, including thoracic and abdominal part, the esophagus has both layers composed of smooth muscles. Esophagus is lined by a stratified squamous epithelium which extends distally to the scamocolumnar junction. It joins the esophagus is separated from the pharynx by the upper esophageal sphincter, which is normally closed due to the tonic activity of the nerve spine the cricopharyngeus muscle. The lower esophageal sphincter consists of 2 to 4 centimeter zone, which is at the end of the esophagus, that has a resting tone and assisted by diaphragmatic sphincter. The lower sphincter responsible for the prevention of the gastric reflux, that is the prevention of the stomach contents entering into the esophagus. The basic anatomy in the upper esophageal sphincter, then body of the esophagus and the lower esophageal sphincter. And normal phases of swallowing are the voluntary phase, which includes the esophageal phase. The bolus is moved into the pharynx, upper esophageal sphincter relaxation, and next is the involuntary phase, which is peristalsis in the esophagus and relaxation of the lower esophageal sphincter. Between swallows, the upper esophageal sphincter prevents air entering the esophagus during inspiration and prevents the esophagopharyngeal reflux. Lower esophageal sphincter prevents gastroesophageal reflux. This shows the swallowing center, normal swallowing, the center in the frontal lobe, then brainstem, the motor nuclei, and the oropharynx and esophagus. Disorder esophagus, first of all, I'll briefly discuss the spastic motility disorder of the esophagus. Now, spastic motility disorders of the esophagus include diffuse esophageal spasm, nutcracker esophagus, hypertensive lower esophageal sphincter, and non-specific esophageal disability. The important topic in this category is diffuse esophageal spasm. What is meant by diffuse esophageal spasm is a frequent non-peristaltic contractions, simultaneously onset of the contraction in 2 or more recording leads. It occurs with 30% of the wet swallows and up to 10% may be seen in normal individual occasionally. It can occur at any age, but it's more after the age of 40, slightly more common in females than the males. The presentation is the dysphagia to solids and liquids, intermittent and non-progressive, present in 30 to 60%, more prevalent in diffuse esophageal studies. Second feature of diffuse esophageal spasm is a chest pain, which is constant. Swallowing is not necessarily affected, It can mimic a cardiac chest pain. And sometimes there are symptoms resembling the IBS. Symptoms and manometry studies, they usually correlate very poorly. This X-ray shows the barium swallow, and they show the diffuse esophageal spasm. Another view of the barium swallow, and you can see the arrows which showing the diffuse spasm of the esophagus. Still another view. The hypertensive lower esophageal sphincter. This means there is high lower esophageal sphincter pressure, more than 45 millimeter mercury. Peristalsis is normal, often overlaps with other motility disorders. A diagnosis of spastic motility disorder of the esophagus with the manometry, barium swallow, as I showed initially, endoscopy, and pH monitoring. What's the treatment of motility disorder? Reassurance, we give nitrates, anticholinergic, hydralazines, but still all are unproven. Calcium channel blockers help in some cases. Psychomotor drugs, imipramine, sertraline, have some effect on it. The main disease which comes in the esophageal disorder is eclasia, and commonly known as cardiac eclasia. This was first clinically recognized esophageal motility disorder described in 1672. Whalebone bogie term in 1929. Now, epidemiology of this disease: 1 to 2% per 200 population, 1 to 2 per 200 population. Prevalence between the age of 40 to 50, slightly more common in male than female. Caucasian is slightly more common in Caucasians. Every symptoms duration diagnosis is 2 to 5 years, which means that when the patient reports initially to the physician, symptoms are already present for the previous 2 to 5 years. जरा पीछे को नजर नहीं आ रहा जरा इसकी जगह चेंज कर रिमूव कर थैंक यू usually present between ages of 25 to 60 years, slightly more common in males. Every simple duration, as I mentioned, 2 to 5 years. Slide नहीं कर रही चल ठीक है okay. Now what is pathophysiology? There's degeneration of inhibitory neurons that affect relaxation of the lower esophageal sphincter, and basal lower esophageal sphincter pressure rises. So basically is degeneration in esophageal sphincter, loss of ganglionic cells in the meningeal plexus. What is its end result? The dual disorder, lower esophageal sphincter fails to appropriate resistance to the flow into the stomach, not spasm of the increased basal There is loss of peristalsis in the distal two-thirds of the esophagus. The sphincter fails to appropriately relax the abnormality and loss of peristalsis in distal two-thirds of the esophagus. Dilatation. What's clinical presentation of eclampsia? It complains of dysphagia, mainly to the in 100% of patients. 75% patients, all patients have dysphagia to the solid food and liquids. There is post-prandial regurgitation after patient swallows the food that occurs in chest pain because of figures, weight loss, of a recurrent aspiration because some material is retained in the dilated portion of the esophagus that moves up during sleep that can stimulate the receptors in the larynx or the pharynx that results in cough and there is a recurrent diagnosis of the first investigation which we advise to these patients: chest, wide mediastinal shadow, absent gastric bubbles, which we normally see in these exercises, and sometimes the pulmonary infiltrates because the aspiration of the contents from the esophagus into the trachea and the bronchi. Here you can see this is dilated portion of the esophagus, this behind the cardiac shadow. Again, another view. This is a dilated esophagus behind the cardiac shadow. Another view. Next investigation, the main investigation, that is a barium swallow. That shows the dilated esophagus with separate lower esophageal sphincter. That is not. So you can see it's a dilated, tremendously dilated esophagus, and this bird peak appearance. So this portion is extremely dilated, and this is narrow portion, lower end. Esophagus is dilated with a bird's peak tapering of the distal esophagus. This is bird peak tapering. Retained secretions from the, you can also see the dilated portion, retained secretions, some bubbles at this area. This is classical appearance of barium swallow. Okay, again, the dilated portion, and then it is a narrowed portion. This also shows, and this is a narrow portion. Next investigation, endoscopy. Endoscopy is not done to diagnose this disease, but it is done to rule out gastroesophageal junction tumors, especially above the age of 16. So this is a pneumonia of the esophagus. The third investigation is esophageal manometry. Esophageal manometry, that shows the absent peristalsis, decrease left lower esophageal relaxation, and resting lower esophageal pressure is more this results complete lower sphincter relaxation. 150 millimeters. This is the results complete lower sphincter relaxation. 150 millimeters. This is the results complete lower sphincter relaxation. 150 millimeters. This is the results complete lower sphincter relaxation. 150 millimeters. This is the results complete lower sphincter relaxation. 150 millimeters. This is the results complete lower sphincter relaxation. 150 millimeters. This is the results complete lower sphincter relaxation. 150 millimeters. This is the results complete lower sphincter relaxation. 150 millimeters. This is the results complete lower sphincter relaxation. 150 millimeters. This is the results complete lower sphincter relaxation. 150 millimeters. This is the results complete lower sphincter relaxation. 150 millimeters. This is the results complete lower sphincter relaxation. 150 millimeters. This is the results complete lower sphincter relaxation. 150 millimeters. This is the results complete lower sphincter relaxation. 150 millimeters. This is the results complete lower sphincter relaxation. 150 millimeters. This is the lecture. Treatment of the eclasia goals: reduce lower esophageal sphincter pressure. Second is increase empty. Measures to take which can lead to reduction in the lower esophageal sphincter pressure and increase emptying of the esophagus into the stomach. Drugs which can help in this regards are and calcium channel blockers, isosorbide dinitrate. This drug reduces the lower esophageal sphincter pressure 66% for 90 minutes, up to 90 minutes for 66%. The calcium channel blocker, nifedipine, reduces lower esophageal pressure 30 to 40% for about 60 minutes. 50 to 70% initial response and less than 50% at 1 year. Used in these cases, botulinum toxin prevents ECH release at the uh, 90% initial response, 60% 1 year. Balloon dilatation, but that disrupts the. This helps in 60 to 95% initial success and 60% at 5. Recent series suggest that 20 to 40% will require redilatation. The success increases about 1 to 30%, usually 3 to 5%. That can cause death in 2 to 0.4% cases. Surgical myotomy that is minimally invasive procedure, more than 90% at 20 years, 85% at 5 years, intensive invasive techniques. Mortality less than 1%. The next esophageal disorder is esophageal strictures. Esophageal strictures means an esophageal stricture is a gradual narrowing of the esophagus which can lead to swallowing difficulties. Scar tissue that builds up in the scarring occurs, the lining of the esophagus becomes stiff. In time, as this particular area. Now, what are the reasons of esophageal strictures? Diabetic gastroesophageal reflux disease, webs and rings in the esophagus, carcinoma of the esophagus, eosinophilic esophagitis, extensive compression from the bronchial carcinoma, that is outer compression from the outside the lung tube compresses the esophagus, and that leads to the development of the stricture formation in the esophagus. Corrosive injections that can cause stricture formation. Post-radiation, radiation therapy to the patient for some other disease like lymphoma, like mediastinal tumor, like thymomas, that can result in stricture formation in the esophagus as a result of the radiations. Now, stricture can also develop following, particularly a patient from severe the biophosphonates. What's the clinical picture of the stricture? Heart patient complains of sensation after taking meal, difficulties swallowing. You can see the stricture at this point. Put a long stricture. This is again showing a stricture. This is long, narrow stricture. This is endoscopic appearance of the strictures. Different views. What's the treatment of the esophageal stricture? Dilatation. The esophagus is stretched by passing a dilator or air-filled balloon is passed through an endoscope to dilate the esophagus. Repeated dilatation may be necessary to prevent the stricture from returning or recurrence of these strictures. Esophageal stricture treatment. Next is if this is if is performed, the stricture can't be dilated enough to allow solid food to pass through the stricture. Surgery is also performed if repeated dilatation do not keep these strictures from returning. For example, if the patient comes to you and we have advised the dilatation repeatedly and that doesn't work, then the surgery is indicated. Then esophageal bypass grafting, different procedures is done by the surgical specialists. So eclasia, then the strictures and diffuse spasm. Next disorder which can affect the esophagus, the neoplastic disorders. There are two types: benign tumors, usually leiomyoma. Benign tumors are usually leiomyoma. Usually these patients are asymptomatic, but may cause bleeding. Stem cell of these, but you know, occurs in the lower third. So basic difference between squamous cell and adenocarcinoma. The risk factors: smoking, alcohol, chewing betel nuts or tobacco, eclasia of the esophagus, a celiac disease, post-cricoid web, tylosis. So these are the risk factors. Nishan, Nishan. Acha. The what are etiological factors? That is smoking, alcohol, chewing betel nuts or tobacco, eclasia of esophagus, celiac disease, post-cricoid web, and tylosis. The clinical features of carcinoma of the esophagus: there's a progressive painless dysphagia to solid food. Progressive painless dysphagia mainly to the solid food. Weight loss, chest pain, hoarseness, pneumonia, ocular effusion, coughing after swallowing, uh, cervical lymphadenopathy because of the secondaries, severe cachexia because of malabsorption, and there's evidence of the metastatic disease somewhere else like lymph nodes, liver, brain. Investigation, the main investigation is upper GI endoscopy. You can see the tumor mass in the lumen of the esophagus. Again, another view, the tumor mass in the lumen, this is carcinoma, in this video. Various studies that shows the irregular filling defects. Irregular filling defects here. Two views, you can see this. And the view of the barium swallow. This is irregular appearance of the esophagus. See, this is a very here filling defects. You can see this. Another view. This is esophagus. Barium is coming down, and there is narrowing in the flow, which shows there is a lean at this place, which is causing narrowing. CT scan. It shows the CT scan showing adenocarcinoma in the lower esophagus. This is the point. Again, another view, CT scan. Show this. Ultrasound, this is done to determine the depth of the penetration of the tumor into the esophageal wall. Biopsy, this is confirmatory to have the tissue diagnosis. When the endoscopy is done, at the same time, the biopsy sample is taken for the tissue diagnosis. What's the treatment? The main treatment of the carcinoma of the esophagus is surgery. For early cases, endoscopic submucosal dissection is done. Radiotherapy is done in cases of squamous cell carcinoma because other tumors are not radiosensitive. Squamous cell carcinoma is radiosensitive. So surgery for early cases. In early cases, endoscopy submucosal resection followed by radiotherapy in squamous cell carcinoma. Then another procedure is endoscopic laser therapy. Sometimes the metallic stents are passed to improve the passage of the food from the pharynx to the stomach. And palliative radiotherapy is done just for the improvement in the symptoms of the patient. Not this is not curative, this is palliative. For example, the advanced disease of the esophagus cancer, we just want to make the uh, patient life comfortable and some symptomatic improvement. In that case, the palliative radiotherapy is done that can reduce the size of the tumor. And next disorder of the esophagus is hiatus hernia. This is mainly this is a topic which is to be covered by a surgical specialist. I just tell you types of hernia. Detailed lectures by surgeons. This is basically a surgical topic. Types of pathophysiology and classification. Type 1 is sliding esophageal hernia. Type 2 is paraesophageal. And type 3 para and sliding, both components there. And type 4 other vista also involved in addition to the esophagus. The presentation is that postprandial fullness in about 63% of the patients, reflux in 31 patients. Patient can have dysphagia, which appears in about 34% patients, bleeding in 24% patient, regurgitation, vomiting in 36% patient, dyspnea in 11%. Different views. The treatment of the hernia is surgical. As I told you earlier, this is a subject which will be covered by surgical side. Just any questions from student side? इसको जरा बुला जरा. स्टूडेंट जो क्वेश्चन आंसर कैसे करेंगे?
Mm-hmm.
Any questions from the student side? कल आधा था स्टूडेंट साइड नहीं आ रही. वो लिखा आ जाता है, वो आ जाएगा. हाँ, वो